Extract 1. Questions 1 to 12. You hear a physician talking to a new patient, called Mrs. Delilah. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor.
Yes, Miss Elissa, what's your problem?
I'm getting acne from continually washing the area around my chin, right temple, and left temple, and the condition is still worsening.
What's your age?
19.
How old were you when you started your period?
Well, it was when I was 13.
And can you describe the length of your cycle?
Once in 24 days, and it lasts for almost 6 days.
Would you describe the flow as light or thick?
It's light.
Do you use any medication?
Yeah, I take the oral contraceptive pill.
Are you allergic to any drugs?
Yes, allergic to penicillin. I feel difficulty in breathing.
What are the medicines you are taking?
Elissa 28, 20 mcg, 0.10 milligram tablet.
Is anyone in your family prone to any disease?
Yeah, my mom has stress disorder and anxiety.
Do you smoke or drink?
I don't smoke, but I drink socially.
You drink caffeine?
Yeah, 4 servings a day.
Your diagnosis report shows you have symptoms of periodic reddening of face, acne problems, and allergies. And a diagnosis of epicrine and apocrine glands shows no evidence of hyperhidrosis, chromhidrosis, or bromhidrosis. But your face shows keratotic papule. I would suggest you go for antibiotic therapy. Take a tetracylin, 250 milligram capsule. I would also suggest you take an oral antibiotic therapy with doxycyline, 100 milligrams a day.
Doctor, why does the acne occur?
Acne is a skin condition that happens when your hair follicles become clogged with oil and dead skin cells. It often results in blackheads or pimples, whiteheads, and often appears on the face, chest, forehead, chin, shoulders, and upper back and shoulders. Acne is most common among teenagers, like you. The androgen hormones increase during puberty, causing the sebaceous glands to enlarge and secrete more sebum. Hormonal changes during pregnancy and the use of oral contraceptives also impact sebum secretion. Moreover, low amounts of androgens circulate in the blood can still worsen acne. Medications such as drugs containing corticosteroids, testosterone, or lithium worsens the disease.
Which food should I avoid, doctor?
Certain dietary factors, such as skim milk and carbohydrate-rich foods such as bagels, bread, and potato chips, worsen acne.
Can you recommend any effective foods for acne?
You must stop eating processed sugar, caffeine, dairy products, and processed foods. And you should include foods that are rich of antioxidants, anti-inflammatory compounds, and other acne-fighting nutrients. Foods such as blueberries, sweet potatoes, green tea, carrots, cilantro, spearmint, oats, apples, barley, and mustard greens.
Okay. Thank you, doctor.
Thank you.
Extract 2. Questions 13 to 24.
It up onto the computer later on. Okay. So just in your own words, tell me what's brought you in today.
Well, I've been getting some diarrhea, really. Yeah, for the last sort of, 2 or 3 weeks.
Okay, so before 2 or 3 weeks, no problems really?
So before that, no. I mean, I've just been going normally, which is once every couple of days or something. Yeah, no problems normally.
Okay, so just tell me a little bit more about the diarrhea, what it's like and things like that.
So like what my poo looks like, sort of thing. Okay, so it's quite it's runnier, sort of looser than normal. I don't think there's any change in like colour or anything. And I probably, but I'm just going a lot more often.
Can I just check? Do you have any blood in it at all?
Oh, gosh, yes. I'm surprised I haven't said that already. It's worrying me. Yeah, that I've had for a couple of days.
And is it difficult to flush away at all?
No, it's not difficult to flush away.
Yeah, and do you ever see any food that's not digested properly in it?
No, that wouldn't be something. No.
So you said diarrhea, but how many times a day does it actually happen?
Well, I would say somewhere between. Well, at the moment, probably somewhere like yesterday was probably about 8 times.
8 times, dear.
I mean, I don't think it's been like that every day for the last 3 weeks, but
up to 8 times a day.
Up to 8 times, yeah.
Do you have to get up at night to go to the toilet?
Yes, yeah.
Oh dear.
Yeah, and I've never had to do that before.
And you're losing sleep over it?
Oh, yeah.
And do you have any tummy pain at all?
Yes, it's quite sort of crampy, mainly just before I go to the toilet, but it can be at other times.
But then does that pain go away once you've been to the toilet?
Yeah, a little bit. Yeah, I would say so. A little bit.
And does anything make the pain worse at all?
Just eating. I don't. Not that I can really think of.
And you pointed to your tummy. Exactly where is it?
It is just sort of around the middle, really.
Yeah. And how do you describe that pain?
It's sort of crampy.
Crampy
I guess.
is what you said, isn't it? Yeah. And how bad is it? If 10 was excruciating and 1 was very little pain, then where would you put it?
It's not. I've had worse. So probably about 4.
Yeah. So it's not agonising, but it certainly is there.
Yeah.
Okay. And you've told me about when it comes on and what makes it a little bit better and worse as well, which is good. So I'm just going to ask the rest of the questions just about the whole gut itself. Do you have any difficulty chewing your food at all?
Oh, no.
No mouth ulcers or anything like that?
No.
Any difficulty swallowing your food at all? Do you ever get indigestion?
No.
Not really.
Sometimes, maybe on a weekend. Sometimes.
Okay, but not usually.
No, not usually.
So this was only about 3 weeks ago that you've had the problem.
Yes.
Okay. And prior to that, what was your bowel habit like?
I don't go that often, really. It's sort of maybe once a day, once every 2 days.
Once a day, once every 2 days, but certainly no diarrhea.
Oh no.
And a normal form stool.
No, it's quite harder. If anything.
But no blood, not black at all.
No.
Okay, that's great. Thank you very much for that. On to your past medical history. Any operations in the past at all?
Yeah, I did when I was sort of in my teens. Probably, I think I was about 15. I had my appendix removed.
In your teens, okay, but nothing since then. No big operations since then.
No.
Okay. You said that you take a little bit of paracetamol for your headaches.
Yes. Yeah.
Okay. And are you doing any of the medicines at all?
Just the pill. Yeah. No, nothing else.
Nothing else at all. Okay. And nothing else over the counter?
No, just paracetamol for my headache.
Any recreational drugs at all?
No.
Okay. And are you allergic to anything?
Oh, yes. I'm allergic to amoxicillin. So is that penicillin?
Yeah.
So we're allergic to penicillin.
Okay. What happens when you have penicillin?
Oh, that's what I get. That's when talk about a rash. I get a rash.
Oh, I see. So that's the rash.
Well, no, but yeah.
Yeah. Okay. So rash with penicillin. So who's with you at home?
Yeah, so I live with my partner, Sam.
Okay, no particular problems there at all?
No.
Okay.
Been together about 3 years.
Is there any family history of note?
No, not that I'm aware of anyway.
No gut conditions in the family?
My aunt maybe. My aunt had something to do with her tummy, but I don't know what it was really.
Okay.
It wasn't cancer.
So just moving towards the end, I just wanted to explore your ideas, concerns and expectations really. So what do you think is going on with this problem?
Well, I think it could be an infection.
An infection, yeah. And you told me about one of your concerns about passing it on to people at work, and especially the children, I guess. Yeah. But any other concerns?
Well, they pass on to me.
Yes.
My sister, my friend's sister, has got bowel cancer, and she's only 30.
Oh dear.
And so it's just the bleeding, really, more than anything that's worried me. So I wondered about that, really.
I mean, I'm glad you told me that. We'll try and reassure you, and let's see what turns out in your case. What do you think we need to do today to help you?
Well, I wondered if I might need some tests. I mean, I'm really hoping, because I did have a little look on the internet, and I'm really hoping it's not going to be one of the cameras. I think it's colonoscopy or something like that. I'm hoping I don't have to have that.
Sure. Okay, I think I've got everything there. Is there anything else that you want to tell me? Actually, I've just remembered, I forgot to ask you about travel. Have you had any travel in the last few months or weeks even?
No, I haven't been away anywhere.
Okay, and you can't distinctly say that this is due to a particular food that you've had, or and nobody else has had this problem in your family?
No.
Just wanted to check that.
Yeah.
Okay, so is there anything else that you want to tell me about this problem?
No, I did go travelling about 3 years ago to Africa.
All right, 3 years ago.
Yeah.
Okay.
I went to South Africa and up into Zimbabwe.
But were you well there, though?
Yeah, I was well. Yeah.
Okay.
Yeah.
Okay. And do you have any questions for me?
No. How likely is it that I'm going to have a camera?
Well, I think initially we'll probably run some blood tests and do the stool sample, and make sure there's no infection. Then I probably need to get a gut specialist to have a look at you if it hasn't got better in a matter of weeks.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at question 25. You'll hear a discussion between a nurse and a physician explaining about Nipah virus. Now read the question.
Hello, doctor. Can you explain what the Nipah virus is?
Well, Nipah virus is a member of the paramic severity genus Henipavirus. This Nipah virus was initially identified and isolated in 1999 during an outbreak of encephalitis and respiratory problems among pig farmers and other people with close contact with pigs in Singapore and Malaysia. The name of the virus originated from Sungai Nipah, a village in Malaysia where pig farmers became sick with encephalitis. Initially, the disease was linked with Hendra virus, emerged from bats, but was quickly singled out for investigation, and flying foxes of the genus were subsequently identified as the reservoir for the Nipah virus. Question 26. You hear a monologue of a physician explaining about the use of thimerosal in vaccines. Now read the question. Thimerosal is a mercury-based preservative that has been used for many decades in the US in multi-dose vials of medicines and vaccines. There is no significant evidence of side effects caused by the mild doses of thimerosal in vaccines, except for minor reactions such as redness and swelling at the injected site. However, during 1999, the Public Health Service agencies, the American Academy of Pediatrics, and vaccine manufacturers agreed to reduce or eliminate thimerosal usage in vaccines as a precautionary measure. Methylmercury is obtained from certain kinds of fish. A high exposure to methylmercury can be toxic to people. However, over a lifetime, everybody is exposed to some methylmercury. Thimerosal contains ethyl mercury, which is the most widely used form of organic mercury that is cleared from our body more quickly than methylmercury and is likely to cause any harm to the individuals. Question 27. You hear a discussion between two doctors on adjuvants used in vaccines. Now read the question. Doctor, what is an adjuvant and why are adjuvants added to vaccines? Well, an adjuvant is used in vaccines to create a stronger immune response in patients. Certain vaccines made from dead or weakened germs contain naturally obtained adjuvants and help the human body produce a strong protective immune response. These vaccines often must be made with adjuvants to ensure the body produces an immune response strong enough to protect the patient from the germ he or she is being vaccinated against. In the US, monophosphoryllipid A and aluminum are used as adjuvants in the vaccines. Monophosphoryllipid A has been used as an ingredient since 2009 in the vaccine called Cervarix. Aluminum salts or gels are used as ingredients in vaccines since 1930. However, most vaccines developed today include just small components of germs, such as their proteins, rather than the entire virus or bacteria. Question 28. You hear a monologue of a physician explaining about typhus fevers. Now read the question. Typhus fevers are a group of diseases caused by bacteria spread to humans by chiggers, lice, and fleas. Typhus fevers include murine typhus, scrub typhus, and epidemic typhus. While the chigger spread scrub typhus, body lice spread epidemic typhus, and fleas spread murine typhus. Typhus fevers include murine typhus, scrub typhus, and epidemic typhus. While the chigger spread the scrub typhus, body lice spread epidemic typhus, and fleas spread murine typhus. Fever, headaches, and sometimes rash are the most common symptoms of the typhus fevers. Epidemic typhus, also known as louse-borne typhus, is an uncommon disease caused by a bacteria called Rickettsia prowazekii spread through contact with infected body lice. Though epidemic typhus was responsible for millions of deaths during earlier centuries, today it is considered a rare disease. Epidemic typhus is called sylvatic typhus in the US. It occurs very rarely. Scrub typhus or bush typhus is a disease caused by a bacteria called Orienta tsutsugamashi. Question 29. You hear a discussion between two doctors about VX and its effects. Now read the question. Hello, doctor. What is VX and how is it obtained? VX is a man-made chemical warfare agent classified as a nerve agent, which are the most toxic and rapidly acting of the known chemical warfare agents, which are similar to pesticides called organophosphates. Symptoms will start appearing within a few seconds of exposure to the vapor form of VX, while the appearance of symptoms may take from a few minutes to 18 hours of exposure to liquid form of VX. Compared with a nerve agent called sarin, VX is much more toxic by entry through the skin and much more toxic by inhalation. Since VX is the least volatile nerve agent with the slowest evaporation level from liquid to vapor, it can be a long-term threat as well as a short-term threat. Question 30. You hear a monologue of a doctor briefing about rubella disease. Now read the question. Rubella is a contagious disease caused by a virus, which is also known as German measles. However, the disease is caused by a different virus than measles. With MMR vaccine, rubella disease can be prevented. This vaccine protects against 3 diseases: mumps, rubella, and measles. Rubella was a common disease in the US before the invention of vaccines. The last major epidemic occurred between 1964 to 1965, when there was an estimated 12.5 million rubella cases in the country. However, rubella was completely eradicated due to successful vaccination programs in the country since 2004.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You now have 90 seconds to read questions 31 to 36.
Stacey, I thought this article was really fascinating, not least because after years, maybe decades of debate on the downsides of medicine and overdiagnosis, it seems quite incredible that we don't quite know what we're talking about still. And you seem to have been working hard to really try and understand and define what too much medicine is. Can you set the scene for us a bit and tell us how you got into this and why it's important to try and define these concepts?
Yeah, absolutely. So, as you know, Helen, this paper kind of started with a really interesting experience at the second International Overdiagnosis, or Preventing Overdiagnosis conference. We all talked about overdiagnosis animatedly for 3 days, and we had a sense of solidarity, and we agreed that this was a problem and it needed to be fixed. And then on the fourth day, there was a special invitation-only meeting of experts, so just people that were really engaged with research about overdiagnosis to try and set the research agenda for the next 12 months. And the very first session was called, I think, Nailing Down the Definition of Overdiagnosis. There was 2 hours devoted to this session. And so these are all people who've been thinking about overdiagnosis a lot. And it became apparent within the first 15 minutes that there was no way that we were going to nail down a definition of overdiagnosis that day, because everyone was using the word in a slightly different way. So we all had this general shared intuitive sense that we were all interested in the same problem or similar problems or related problems, but we weren't completely clear what we meant when we said this word, overdiagnosis. So we came away from that meeting really motivated to try to unpack why that could be, why these very well-intentioned, very smart, expert people were not using this word in exactly the same way.
And why is it important to have clarity on that word? What's it stopping us doing, or what conversations can't we have without its definition?
I think overdiagnosis is such a difficult thing to approach in policy terms, in clinical terms, and I find it, even just talking with my friends about overdiagnosis, it's quite counterintuitive, and it can be very difficult to talk about in a way that convinces people that it is a problem that we need to do something about. I think if we're not clear ourselves what we're talking about, it becomes very difficult for us to be clear with policymakers and with the general public that this is a problem that we need to do something about. And we also, if we're not clear, I think we potentially waste a lot of energy within the research and clinical community talking at cross purposes. If we're all using the word to mean different things and talking past each other, we waste a lot of energy. But if we can be clearer amongst ourselves what exactly this problem is that we're trying to solve, we've leaped the first hurdle towards trying to solve the problem. And the problem, really, I think the people that are focused on the problem of too much medicine are really mostly concerned that medicine is harming people when it doesn't mean to, and that we're allocating resources in a way that doesn't get the best benefit for the people who need medical care. So it's motivated by good reasons, wanting to prevent harm and wanting to make sure that there's the maximum amount of benefit. But until we're clear exactly on what overdiagnosis is, it's hard to achieve those things that we're trying to achieve.
And what are the key themes that emerge? Because I went to some of your sessions, and you might think walking into the sessions at the conference that overdiagnosis is quite a numerical, black and white issue. But actually, in the setup of this article, you explain that it's actually far more complicated than that, and to an extent, overdiagnosis or too much medicine is in the eye of the beholder, and there's a lot of judgment and ethics and messy stuff in there. Tell us a bit about that.
It's true. So part of the challenge of overdiagnosis is that it's a really complicated scientific problem. So there's amazing people, including my colleague Alex Barrett, who you'll be speaking with later, who've dedicated many years of their career to trying to work out how to produce accurate, trustworthy scientific measurement of the size of overdiagnosis. So it's definitely a scientific problem. But we can't reduce it just to some kind of ideal of value-free science where we just get the maths right and then we know how big it is and then we know what to do. And the reason for that is that overdiagnosis is fundamentally about, or too much medicine is fundamentally about trying to identify the situations in which medicine is doing more harm than good, or medicine is not delivering a net benefit. And as soon as you start talking about harm and benefit, you're in the realm of ethics. You're in the realm of weighing up goods and bads. And as soon as you start talking about harm and benefit, you have to ask, as you said, from whose perspective? So whose ideas about harm and benefit should matter when we weigh up whether to do a particular test or whether to offer a particular drug? Should it be the patient's assessment of benefit and harm, the clinicians, researchers, all of them? If they disagree, how should we adjudicate between them? If there's different benefits and different harms that all have to be weighed up, then how do we do that weighting? So, and that's moral territory, it's ethical territory. So that needs to be a conversation that is quite explicit, and a conversation that brings in citizens, that brings in the public, which is why it's so important to have good public conversations about too much medicine. And if we want to address too much medicine, we also need to recognise that it's a social problem. You know, this is a problem that comes from the social systems that we humans create for ourselves. So it's driven by things like clinicians who are pushed and pulled by incentives and penalties in the systems that they work in, and clinicians who feel threatened by medico-legal threats to do more testing and to make sure that they've covered every base, or companies who are required to make a profit, and so they might sell tests or sell drugs harder than they should to try and make more money, or things like the increasing rise of direct-to-consumer selling of tests like genomic tests. So, spit in a vial and send it off in the post, and you can get information about your genome sent back to you in a couple of weeks. So these social forces are an important part of what creates overdiagnosis, what motivates it, what drives it. So if we're going to be able to address it effectively, we've got to acknowledge and take seriously that social aspect of overdiagnosis or too much medicine. So the science is critical, but the ethical and social dimensions are just as critical, and in fact should feed into the science if it's going to be good science.
So setting out these definitions must have been no easy thing, and it sounds like there's a huge grey zone in terms of how we're going to be able to think and deal with them. In your article, you've got an enormous table, I guess informed by the opinions of all these different experts who were feeding in their thoughts about what overdiagnosis was. Can you explain for the readers some of the broad themes that are in there?
Yeah, absolutely. So what we tried to do was to get to the bottom of a difference, actually, because when we thought about why those well-intentioned, super smart experts in that room couldn't agree on what overdiagnosis was, we concluded that it was possibly because they were using that word at two different levels of generality. So that some of those experts were using the word overdiagnosis in a very specific way to mark out a very specific concept. And we argue in the paper that this is how the word overdiagnosis should be used, that we should start restricting it to a narrow sense. And that sense is really about the boundaries of the definitions of conditions. So the narrow sense of overdiagnosis, which is the first line in our table, is when a person is diagnosed with a condition, but that diagnosis doesn't produce a benefit for that person. So it's a very particular problem, and it's about rethinking the boundaries of diagnoses, diagnostic categories, and thinking about those boundaries not in terms of can we make sure that we find every case, or can we make sure that we treat every person, or can we leave no stone unturned, but instead it's about thinking what will the benefits be, what will the harms be, how can we weigh them up against each other, how can we be sure that the benefits are likely to outweigh the harms. So that concept of overdiagnosis is quite narrow, quite specific, and it really needs to be. Yeah, it is. It's about when is it a good thing to label this person? So when is it likely to benefit this person to give them this label? And it really has to be negotiated condition by condition, because that decision obviously has to be made in collaboration between the clinicians and the patients and the researchers that are working on that very particular problem. So overdiagnosis in that narrow sense, we're arguing in the paper, should be the only way that we use the word overdiagnosis. And we've adopted the BMJ term, too much medicine, to encapsulate a whole lot of other problems that are related to but not the same as.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
New research from the Perkins Institute at the University of Sydney claims to have found the diet that boosts FGF21 levels. One of the lead scientists on the study was Samantha Solon-Beat of the Perkins. Welcome to the Health Report.
Thank you for having me.
So what is this stuff, FGF21? I mean, it's almost eye-crossingly complicated from the look of it.
Yeah, it seems complicated, but it's actually not. And recently, there's actually been an immense amount of interest in fibroblast growth factor 21, or FGF21. And this hormone has actually recently been called this fountain of youth hormone, which we know can be influenced by diet. And the reason why FGF21 is so interesting is because high levels of this miracle hormone, as it's called, has actually been shown to play a huge role in influencing appetite, improving metabolic health and immunity, and even extending lifespan in mice.
Now, something that sounds so good to be true is usually too good to be true.
At this point, there are no adverse effects shown with increased levels of FGF21. In fact, a lot of studies are now being done to investigate FGF21 as a therapeutic target for the treatment of diabetes and cardiovascular disease.
Let's just double back, Sam. A year or so ago, we had Steve Simpson, who's the director of the Perkins Institute, talking about this 25 diet study where they studied 25 diets in mice to see if you could replicate the life-prolonging effects of a low-calorie diet, where extremely low-calorie diets in some animal species, in fact all animal species, it seems, apart from humans because it's not been proven yet, increases life expectancy or lifespan. Is the FGF21 really the heart of this matter?
We think it actually could be. Certainly in this study, we've shown that a diet low in protein and high in carbohydrate is the most effective way to increase levels of this miracle hormone. And that this diet was also associated with several markers of improved metabolic health in mice.
So tell us a little bit about this study.
Well, what we actually did was performed a really large mouse study, as you said, where we took 858 mice and offered them a range of different diets to see how macronutrients, such as proteins, carbohydrates, and fats, as well as total energy, could interact and influence levels of FGF21.
And you found?
And we found exactly that we could use diet to increase the levels of this FGF21 hormone, and that a low-protein, high-carbohydrate diet was the most effective way for increasing this miracle hormone.
And what effect did that miracle hormone, I hate using that word, that phrase, but what effect then did the hormone have on these mice, or were you able to separate the two?
We were actually able to show that the exact diet that increased FGF21 also improved things like insulin sensitivity, glucose tolerance, blood pressure, and blood lipids, even though the animals were a little bit fatter.
And how do you know that was anything whatsoever to do with the FGF21, your so-called miracle hormone, and rather than it just being an accident that it was raised to?
What we did was plotted FGF21 using the geometric framework, which is a nutritional modeling platform that helps us tease apart the role of nutrients and calories. And if you line up all the surfaces, the response surfaces in this framework with FGF21 and all the metabolic outcomes, you can clearly see that there's a specific area in the nutrient space that coincides with increased levels of FGF21 and several metabolic benefits.
And what kind of carbohydrate, and what happened with fats?
In this study, fat did not appear to have an effect on FGF21 levels. It seemed to be low protein was the primary driver, and that the highest combination was with a low protein, high carbohydrate diet.
So what does FGF21 do to the body?
And that's a really good question. And that's really the next step of our study. We want to understand how FGF21 signaling works in response to diet to mediate all these beneficial outcomes.
Do we know that there are any medications affected?
At this point, no.
It seems that it goes up with starvation, it goes up with overfeeding. There's lots of things that influence it. Did the appetite of these mice change? Do they eat more or less when the FGF21 goes up?
Oh, that's a really good question. See, this is one of the things that we were able to reconcile in our studies. As you mentioned, a whole range of literature in previous studies have shown that FGF21 is elevated in many paradoxical conditions such as starvation and obesity, high intake of food and low intake of food, as well as in insulin resistance and in insulin sensitivity. So what is going on here? Using the geometric framework, we were actually able to tease apart these findings, showing that reduced protein intake is the primary driver of FGF21.
Okay, so what happens in mice does not necessarily happen in humans. How do you know it makes any difference at all in humans?
Oh, I'm glad you said that. We've actually published work just this year showing that FGF21 levels in humans is also increased by a low-protein, high-carbohydrate diet. And of course, this is really exciting because it tells us that the work that we do in mice can be directly translatable to humans.
So is there any evidence at all that FGF21 has the same beneficial metabolic effects in humans as it has in mice?
Yes, there is definitely evidence to suggest that high FGF21 levels is directly related and associated with several benefits of metabolic health in humans as well.
So we should put it in the drinking water then, do we?
Yeah, probably. That seems to be the case, yes.
How would it work? I mean, obviously, a hormone like this is probably destroyed in the stomach. This is not something that you would give directly to people, I assume, in the therapeutic context?
At the moment, it's difficult to do chronic administration to humans. So what's happening in terms of drug development is trying to develop mimetics of FGF21 and analogs. So not exactly administering this hormone per se, because it would require chronic injections or chronic administration.
So almost nothing that's touted as a breakthrough or a miracle by scientists turns out to be so. What are your modest expectations of FGF21 in humans?
Well, in humans, we actually think that FGF21 is extremely promising. We think that, at least in humans, we've shown that FGF21...
So a treatment for type 2 diabetes?
Absolutely.
That sort of thing?
Yes, we've shown that humans seem to respond in the same way as mice. So this could mean that we could tailor our diets and our nutritional guidelines to generate a range of benefits from FGF21.
Is it too blunderbuss? You're describing something that sounds blunderbuss rather than targeted. You're just spraying an effect rather than targeting an effect. If you can do anything with it, it's going to be a very wide set of actions which you're going to find hard to control, isn't it?
At the moment, everyone is very interested at FGF21, but no one really knows its mechanism of action. And it seems to be a race at the moment. How does it work? What turns it on? What switches it off? And what can we do to find out more about it? So at this point, I think it's a really hot topic and everyone's racing to find out the answer.
And you hope you'll be first.
Hopefully.
Sam, thanks for joining us on the Health Report.
Thank you so much.
Samantha Solon-Beat is a researcher at the Perkins Institute at the University of Sydney. And on our website, we'll have a link to our previous interview on the diet and longevity study.